না না, সব না, ঢের আছে। দেখ না, খুলো না, তখন বোঝা যাবে।
हेलो सर।
হ্যাঁ, আদা আছে তো, আদা আছে, হ্যাঁ আছে মনে হয়, দেখ আমি দেখে দিচ্ছি। আদা আছে, আদা আছে।
હેલો સર.
બરાબર છે?
યસ.
સંભળાય છે?
યસ.
हेलो हेलो
હા, સંભળાય છે?
हाँ સંભળાય છે ને સુમિત?
યસ.
હા, સંભળાય. તું બોલ ને પેલું. સંભળાય છે?
હા હા
ના,
બે
કેમ?
દિવસ
બે
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 દિવસ
અવાજ આવે.
બે દિવસ સાથે લાગે છે સર તમે.
અચ્છા, ઓકે. તો એક હું બંધ કરું.
હા એટલે એકમાં હા તમારે ઓડિયો ઓફ કરી દેવો પડે.
તો પેલું પેલામાં કંઈક જતું રહે ને, તો એના માટે હમણાં આ બંધ કરી દઉં.
Am I audible?
Yes. Am I audible?
Yeah.
Good evening. Am I audible, sir?
Yes, sir.
Yes.
Yes, sir. Yes, Dr. Dhruv, sir.
Thank you so much.
I think we should wait for 5-10 minutes before commencing.
Waiting for Dr. Krishna madam and the Dr. Anurag, sir. So
Okay.
it's-
Once they join,
Ah,
we start. Already, I think 21 participants are there.
yeah. So if they are joined, we will first start with the blessing of our national president and secretary, then we'll proceed further.
Okay. આમાં જયેશ કોઈ ટાઈમ લિમિટ છે તારા ટ્રાન્સમિશનમાં કે એવું નથી?
ના સર, મારું પેઇડ વર્ઝન છે એટલે કોઈ ટાઈમિંગ નથી.
ઓકે,
We can
40
extend
મિનિટ.
any time. હા.
અચ્છા, ઓકે. Because પેલો unpaid વર્ઝનમાં you have to limit it to 40 minutes.
It's a 40 minutes. ના, my is
એટલે yours is a
paid
paid
version.
version. Okay.
We can do the 100 participants at a time, and if we do more than 100, then we have to go for the YouTube.
Okay.
গার্জিয়ান ডাকবে।
Hello.
Yes, sir.
Yeah.
Pleasure.
Am I audible?
Good evening.
Namaskar.
Namaskar, Anurag sir.
Namaskar, bhai. Namaskar.
Can we proceed, sir?
Yes, please go on.
Okay. So, Indian Society of Study of the Pain, Surat City branch, welcome all of the delegates and our national president, secretary, sirs, and our Surat City branch and all these faculties. Today's we have done the webinar on the myofascial pain and different remedies. First, I will invite the Dr. Anurag sir, who is our national secretary ISSP, give us some few words and blessings to us.
નાની નાની છે એટલે પાંચે પાંચ મૂકી દઉં છું. ઓકે, ફાઇન.
Thank you, Dr. Jayesh, for having me here. And I bring good wishes from the ISSP headquarters at Lucknow. I would like to congratulate the ISSP Surat City branch, Dr. Desai sir and Dr. Jayesh and all the team for having a wonderful topic that is myofascial pain, and wonderful speaker Dr. Khyati Patel and Dr. Our very dear friend Dr. Dhruv Bivra, who is doing a remarkable work in the field of myofascial pain with the help of Botox, which we usually know that it works for the decrease the wrinkles, but actually it can remove the wrinkles of the soul of the chronic pain patients by helping them. And let me assure you that it is a very important topic. We all have seen who have worked since last few years in the field of pain medicine, which deals with the chronic pain syndromes that because of non-diagnosis or mixed diagnosis of myofascial pain, many patients end up with the major big spine surgeries, especially in the cervical spine region, unfortunately so. But as we pain physicians are ought to become the primary custodian of chronic pain syndrome in the coming few years, with the help of you all, I am sure that we will decrease that incident and everything. So with these words, I again convey my regards, best wishes, and more power to all of you pain physicians, especially the younger generation of pain physicians and the future of pain physicians that is largely from background of anesthesiology, our residents, to have more power, work hard, study well, and keep on working. Good luck and good wishes.
Thank you, Anurag sir, for your speech and blessings. We heard remark the presence of our national president, Ma'am Dr. Krishna, Madam. Ma'am, please give the few words and blessing to us.
Oh, ma'am is here?
Ma'am
Okay.
is there.
Okay.
Can we
Namaste,
start
ma'am.
without her? We cannot start without her.
Yeah, I understand, sir. I thought that she might be busy. Actually, I have just landed to my home and
Okay.
yeah.
Yeah. So good evening, everyone, and
Yeah.
I welcome you all. It's a wonderful seminar. So I congratulate first Surat City branch and Jayesh and you for arranging and having this webinar on the fibromyalgia pain and myofascial pain. So it's a very good topic and very complicated because Anurag was right. Sometime patient really led up with the spine surgery or some type of the surgery, or they continue suffering because very hard subject also, very difficult subject also. Patients sometimes go in remission, sometimes then again. So different type of therapy. So it's a good and very informative webinar. So you all enjoy and all the best and keep learning. It's always every time it's good to learn everything from everyone. Like we have very this time you have very good speaker. So keep learning. All the best.
Thank you.
Thank you, Madam, for your nice words and blessings. And we wish that we continue, our city branch will continue regularly such kind
Yeah,
of the
very
webinars
nice.
and physical as well as the offline, online CAB,
Yeah,
sometimes
yeah, yeah.
combined CAB. And we need your support in future
Yes.
also, ma'am.
Yeah,
Thank
yeah.
you so
Good,
much.
good. Yes. Very good.
Now our first speaker is with us, Dr. Khyati Patel. She is working in the Surat as a working in the Surat as a pain physician. She had done his MD anesthesia. She had done the fellowship in pediatric anesthesia and the regional anesthesia from the Coimbatore. She had done the palliative care and the chronic pain fellowship from the Mumbai. So I invited Dr. Khyati Patel to share his view regarding the myofascial pain and the role of the dry needle. Dr. Khyati.
Thank you, sir. So I'll be talking about myofascial pain, mainly focusing on dry needling part of it. So we begin with physiology, how the muscle contracts, and then eventually we'll go to the pathology part and the treatment part of it. So whenever there is a impulse which passes from nerve to the muscle, so initiation of the impulse, action potential reaches the neuromuscular junction. The calcium enters the synaptic. Sorry? Okay, I'll continue. So the action potential, whenever it reaches, the calcium permeability increases. The calcium will then bind to the synaptic vesicle and the acetylcholine will be released in the cleft, which will then bind to the acetylcholine receptors which are on the muscle membrane, and that will increase the sodium channel permeability. The sodium enters inside and the action potential is carried forward. Now, once the action potential is generated at this level, it then propagates along the muscle surface, along the sarcoplasmic retinaculum via T tubules. What happens here is, in the sarcoplasmic reticulum, this is the sarcoplasmic retinaculum, and from there the calcium will be released. So whenever calcium ions are released, they bind to the troponin. Once calcium binds to the troponin, the actin and myosin, the heads, they become free to attach to each other and the muscle can contract. So here as we can see, calcium is binding and now the actin head is binding with the myosin. This whole thing is energy dependent process. Once the actin and myosin, they are bound, the sarcomere contracts and the muscle as a whole will contract. At rest, they are all separate from each other, but when the muscle contracts, they all come together and the muscle will contract. Now, why the muscle remains contracted, that we will see later. But just to revise, sort of, ATP is required in each of the steps, like to detach the actin and myosin so the muscle contraction can stop. Also to pump all the calcium back into the sarcoplasmic retinaculum so the muscle can relax. And also the hydrolysis products are required so that myosin head remains free to contract further. Now why does contracted muscle remain contracted? So there are multiple hypotheses. We will be looking at 2-3 important ones. So first talking about the energy crisis hypothesis. So whenever there is trauma, there will be damage to the sarcoplasmic reticulum as well as the muscle cell membrane, which will increase the calcium inside the cell. And this released calcium will then
Dr.
activate
Khyati,
the myosin. Sorry.
just sorry to interrupt you. Dr.
Yeah.
Jayesh, please mute everybody because she is getting disturbed again and again. Someone has forgot to mute themselves. You can do it as the runner of this program.
Sir, I have changed the setting. Now the
Yeah.
only speaker can.
Yes. Please do that. You
Yeah,
can.
yeah.
Yeah. So whenever there is increased calcium inside the cell, it will cause actin and myosin to contract. So because everything is dependent on energy, that is ATP, over the period of time, there will be shortage of ATP. So with impaired calcium pump, the actin and myosin head will remain stuck together and the sarcomere will remain contracted. So the muscle will continue contracting. That is how the trigger point is formed. There's one more theory called Cinderella hypothesis, which says smaller muscle units are recruited first and they remain recruited throughout the muscle activity, entire duration of the activity. So these small muscle units, they are always working. So it is compared to the Cinderella of the stories. So these slow twitch muscles, they do not get any rest. So there is incomplete recovery and eventually they develop muscle pain. And third and the most famous theory for myofascial pains is integrated hypothesis. So here what happens is whenever there is muscle overuse, disuse or injury, there is excess of acetylcholine released at the neuromuscular junction. And that will cause sustained contraction of the sarcomere, which will eventually cause compression of the blood vessels and reduce the local blood flow. With the decreased local blood flow, there will be hypoxia, acidic environment, as well as inflammatory mediators will increase. And these inflammatory mediators, they then activate the nociceptive TRPV channels and the acid sensing ion channels, and that produces pain, hyperalgesia, and when this persists, there will be also central sensitization. Now, J. Shah et al., they have done extensive research on this topic where they measured inflammatory mediators in the trigger point. They inserted these micro needles into the trigger point. The fluid was pumped in and then it was taken out, and then they measured all the inflammatory mediators. You can go through this paper. It has more than 600 citation on the same topic. And then there are multiple other hypotheses. We won't be discussing all of that. Now coming to myofascial pain. So myofascial pain, it's a syndrome where there is pain in the muscle and the surrounding connective tissue, that is fascia, and it is characterized by the trigger points. Now, what is trigger points? So trigger point is a hyperirritable spot within the skeletal muscle, which is painful when you stretch that muscle or you manually compress that muscle. And this trigger point, it persists in spite of inciting event, even if that has stopped. So it becomes independent nociceptive input, which will propagate the injury further, and the peripheral sensitization will continue. Now, what are the characteristics of this trigger point? So they are the palpable tight bands, hypersensitive spots. When you stimulate it, you will see the local twitch reflex. Here in this ultrasound video, you can see my needle is entering there, and you can see here the muscle, kind of a jerk kind of a thing is there, which is called local twitch reflex. And what this leads to is it can cause restricted range of movement. It can also produce autonomic symptoms. Now, trigger points can be active or latent. So active trigger points, they are spontaneously painful and they produce patient's own recognized pain patterns, and they have larger surface area of the referral zone. Now, what is referred pain? It's a pain which is felt in a region that is different than the source of origin of pain. And then there are latent MTRPs, which are not spontaneously painful, but if you stimulate them or apply pressure to them, only then they become painful. But it will produce pain which is different than the patient's own pain complaint. And they will have smaller referred zone. But both of them can produce muscle dysfunction and can contribute to muscle stiffness, decreased range of motion, and so on and so forth. So how do we identify them? So there are objective tests like vibration sonoelastography, functional MRI and all, but it's practically not possible to do all that either because of cost or unavailability. So we rely on clinical assessment, which will be patient's history, localized muscle pain, referral pain pattern, autonomic symptoms, and manual palpation to look for trigger points and tight bands. Now, what are the general causes for myofascial pain? It could be muscle overuse, ergonomic issues that can cause repetitive strain injuries, sports injury, pain syndromes like fibromyalgia, chronic fatigue syndrome, neuropathy, and metabolic disorders like vitamin deficiencies. And the general treatment line is we start with physiotherapy, hot fomentation, TENS, muscle relaxants, NSAIDs, then comes dry needling and the Botox. So coming to dry needling. So dry needling is insertion of very thin needle into the muscles, but you don't inject anything through that needle. That is why it's called dry needling, because we are not injecting anything. And how does it work is it causes mechanical disruption of the tight band. It reduces the end plate activity, improves the blood flow, and contributes to reducing the peripheral sensitization and hence the central sensitization. So whenever needle is inserted into the trigger point, there will be mechanical reduction in the nociceptive inputs, and it will reduce the irritability of the NMJ, which is motor end plate noise. Now, what is this end plate noise? So, like we saw in the initial slides, this is the normal NMJ, neuromuscular junction. And in a normal neuromuscular junction, even when nerve is not stimulated, some amount of acetylcholine will be released into the cleft, which is around 2 to 6 per second. That is called miniature end plate potential. But this does not generate potential enough for the muscle to contract. Whereas in a trigger point, there is more acetylcholine released. So the MEPP will go up to 100, 110. And when it is traced on the graph, this is how it will look. So here you can see multiple deflections happening, and then suddenly there is enough acetylcholine for the muscle to cause contraction and then become painful. Whereas in a normal muscle, there is just tiny small positive deflection, but nothing enough for the muscle to contract. Now, when we put needle into such trigger point, what happens? So when you insert needle into that trigger point, you are stimulating the afferents, that is A delta and C. And from there, they go to the dorsal horn, to the interneuron, and it's a oligosynaptic or the monosynaptic reflex. So efferents come back at the same level, and it causes involuntary contraction of the same muscle in which you have inserted the needle. That is what is local twitch reflex. A few videos to show what LTR looks like on ultrasound. So here we are inserting the needle, and here you can focus in the red arrow zone, where once the needle reaches that point, you see the tiny jerk kind of a thing. So this LTR, it causes relaxation of reflex relaxation of the muscle. So local twitch reflex, it can be seen if you are doing blind needling or landmark guided needling, you can see twitch in the muscle if it is big enough. If it is ultrasound, then even smaller twitches can be identified. It can be recorded on the electromyography. And here also you can see twitch happening in this area. My needle had already gone inside, and then this contraction is happening there. Now, every time you may not see same kind of twitch. Sometimes you may just see a shimmering kind of a thing. Sometimes this kind of jerky kind of a thing. So this is the sciatic now. The needle has gone already inside, and you can see the muscle twitching over there. So LTR is pathognomic of myofascial pain syndrome. Again, you can see twitches happening only in part of muscle. This is peroneus longus and brevis. Lateral part of the shin is in the view. And the muscle is still twitching. It's been some 5-7 minutes since I have inserted the needle. Now the whole thing is twitching. Okay. Now coming to difference between acupuncture and dry needling, because the moment you say needling, people assume it's acupuncture, but let me be very clear, it's not. So we'll look at what is the difference. So acupuncture is based on the Chinese philosophy, which says imbalance in the meridian is responsible for all the pain and all the diseases. Whereas dry needling, you have to demonstrate that there are some trigger points either on palpation or on ultrasound. In acupuncture, there is no concept of muscle. Whereas if you are doing dry needling, that is landmark-based needling, you will demonstrate jump sign when you press the painful muscle. And on ultrasound, you will demonstrate local twitch reflex. Now in acupuncture, needles are inserted into pre-designated acupoints, which do not have any relation to the anatomy. Whereas in dry needling, you feel for the tight band on palpation and then you put the needle. Whereas if you are doing it ultrasound guided, you will be putting needle into all the layers of muscle, the painful ones as well as its antagonist, agonist. Number of needle in acupuncture, usually 6 to 10 needles suffice. Whereas if you are doing it ultrasound guided, if you see more twitches, you'll put more needles in more muscles. So it depends on what your findings are. For acupuncture, usually done by acupuncturist person who's trained in either Chinese medicine or acupuncture. Dry needling, usually done by physiotherapist. You need to know muscle anatomy. Ultrasound guided needling, usually done by pain specialist who's trained into ultrasound and has knowledge of muscle, sonoanatomy, as well as knows how to steer the needle under ultrasound guidance. Coming to risk, acupuncture can cause neurovascular injury, especially for superficial nerves and vessel. Dry needling, when done under landmark guidance, it can cause serious complications like pneumothorax if you are doing upper back or maybe trapezius area. With ultrasound guided, these risks are not there because you steer the needle under vision, so you know where the lung is, where the vessel is. So only thing that can happen is bruising if you have put more needles. Now, length of needle, acupuncture usually uses 13 to 25 mm. When you're doing it under guidance, you can decide the depth of your target and then pick needle anything from 13 mm to 120 mm. So to summarize, there are many things that can happen simultaneously, like some changes in gene, too much nerve stimulation, too much acetylcholine release, lack of ATP, proteins like titin, which can cause muscle stiffness, and everything will produce trigger points and eventually pain. So take home message from me is myofascial pain is quite common. It's treatable. Dry needling is effective, minimally invasive, and image guidance enhances the safety as well as precision. All right. Thank you.
Thank
Just
you.
share the references. That's it.
Thank you, Dr. Chati, for wonderful presentation. There is a one question in the chat box for you. Is the dry needling gives same pain relief in practice in comparison to adding local anesthetic and steroid? What is your experience?
Okay, so when we are putting local anesthetic or steroid, you are still producing something called needle effect. So you are going to go into the most painful part of the of the area and then inject. So they can act like adjuvant, like doing only needling will produce effect. But when you add steroid or local with it, not in every session, maybe to begin with, when there is too much pain, too much inflammation, and lot of inflammatory markers, starting with steroid injection and then following it up with needling session will be a better way to and kinder way to do it than the only needling.
Thank you so much. Other question we will take in the last to all the speakers. We move to the another session. The next speaker is Dr. Samir Desai. He is a senior anesthesiologist and pain doing the pain clinic, running pain clinic in the Surat. He had done the MD anesthesia and the FIPP from the WIP. I welcome Dr. Samir sir to take his lecture regarding the fibromyalgia and what is the difference between fibromyalgia and myofascial pain, differentiating how to diagnose. Dr. Samir sir. Yes, sir.
Am I audible?
Yes, sir.
Okay. So you have
Uh,
muted me.
Slides, sir.
So I will be able to make it a slideshow. No?
Hi, sir, you can also share, though I can stop the share. You have done, give me the PPT, so I had shared at present. If you can share, then it's a better.
So how do I do it?
Sir, you have to go to the share. First, open the
Okay.
PPT, and then the
Okay.
share. There is a share option is there in the
Okay.
downside, and then you share.
Yeah, I
Okay.
think I've done it.
Yes, sir. No, sir. સર હું શેર કરી દઉં.
Then will I be able to move the slides?
Sir, you cannot able to move the slide. I have to
Yeah.
move the slide.
Actually, I have shared my screen. Okay.
Sir, to go to the first slide, sir. Sir, first slide. Slide is seen, but go to the first slide, sir.
I'm not able to go back.
Go to the PPT, sir, and start from the current slide. First slide.
So I have shared my presentation.
Sir, at present we are not able to see your PPT. Can you share and let him talk?
Okay. So I'm starting to share. Okay.
Yes, sir.
Now I have shared.
Yes.
Okay. Now I need to start from the first
First
slide.
slide. Exactly.
Okay.
Fibromyalgia. Yes.
Okay. I think. Oh,
Sir.
so when I ultimately it ends to the last slide only. Let me see.
Sir, go to the first slide and then down arrow.
I'm selecting the first slide. This is the first slide. Okay.
Sir.
Then I have to go to the slideshow.
Yes, sir.
Okay. Done.
Okay, sir.
So should I start?
Yes, sir.
Thank you. This is a typical case scenario in case of fibromyalgia. 35, 40-year-old female comes to your clinic with complaints of widespread pain. Host of consultants have seen her. Lots of investigations are done, but the patient does not have any relief. And the patient comes to us telling, "Sir, आपके पास आई हूँ. आप मेरे last consultant हो. I want that my pain is relieved." So that's an unrealistic expectation, but then this is what we are presented with. So the whole of the pain management is encompassed into these three sentences. All pain arises from a lesion. All treatment should reach the lesion, and all treatment should have beneficial effect upon the lesion. So there is always a lesion. It could be in the somatic system or it could be in the central nervous system. So first of all, you have to do your own history and physical examination, even if many consultants have seen this patient. Because 80% of diagnosis is made by history and physical examination. Investigations only support your diagnosis. And in this case of fibromyalgia, the role of investigation is always to exclude other diseases. And there is no investigation per se which can label fibromyalgia. And I consider fibromyalgia as a syndrome and not a diagnosis of exclusion. Previously, we used to believe that it's a diagnosis of exclusion, means you have excluded all the possible somatic complaints and whatever remains is fibromyalgia. But no, it is a definite disease entity and it needs proper diagnosis and proper treatment. So how the fibromyalgia ultimately happens? It is an amplified pain signal syndrome. So a noxious stimulus, which a normal person would not feel that much, but in a case of fibromyalgia, those signals are amplified, and it is basically a cause of central sensitization rather than a peripheral sensitization. Myofascial pain, which Khyati described, is a classical case of peripheral sensitization first, and then goes into the central nervous system. And the whole problem is a dysfunction in descending inhibition, means descending inhibition system usually masks the pain of a stimulus. So there is a lack of adequate serotonin and norepinephrine neurotransmitters, which are responsible for reducing pain. There is a genetic linkage, means many people have some of their relatives who suffer from this condition. And patient with some major trauma sometimes develop this condition. And virus infection like Epstein-Barr virus also is linked with the etiology of this syndrome. It is definitely a disease, and functional MRI picks up noxious stimuli when the insular area of the cortex shows some activity to a noxious stimulus in a fibromyalgia patient, where in a normal person those areas do not light up. And their disease is 4 to 6 times more prevalent in females than males. So how do we arrive at a diagnosis? It is a combination of two things, symptoms and signs. The basic symptom is a widespread body pain. American Society of Rheumatology had designated 18 tender points in different quadrants of our body, and 11 of them should be present to be labeled as fibromyalgia. But nowadays, you don't have to follow it very strictly. The basic guideline is that at least 3 out of 4 quadrants of the body should be involved. Along with that, pain, the symptoms of fatigue, sleep disturbances, depression, and cognitive disturbances like a brain fog. The patient describes that she is unable to think properly. And along with that, many patients have headache, temporomandibular joint pain, or chronic fatigue syndrome and irritable bowel syndrome. And this painful condition should be more than 3 months of duration. As I told you that pain in nearly 3 to 4 quadrants should be there. It can be superimposed on somatic diseases like osteoarthritis of the knee or pain in the spine related to degenerative disc disease or facet arthropathies. But the basic problem is fibromyalgia. So the treatment part is you have to first educate the patient that this is a real disease, and mainly the education has to happen with patient's relative, because they are not ready to accept that this condition is serious and this is not purely psychological. So first of all, you have to tell that this is a definite disease, and you have to, I give them some materials, educating materials to them so they can understand the disease. It is a classic case of biopsychosocial problem, and it requires multidisciplinary care. Usually, there are 3 to 4 consultants who can provide multidisciplinary care. One is our pain management specialist, second is physical therapist, and third, a good psychologist. I previously used to some of the difficult cases to rheumatologists because it comes into rheumatology domain also. But what was happening was they also would write the same drugs we write and send the patient back. But for the treatment to be complete, you have to cover all the aspects, biological, psychological, and social aspects also. So the goal of the treatment is to provide pain relief, improve sleep, restore patient's function, treat depression, improve the thinking of the patient. There are 2 schools of thought that should the drugs be tried first or physical therapy is the mainstay. According to me, physical therapy remains the best because drugs will help, but they cannot be taken for lifelong. So initially you can start with drug, but the whole mainstay of the treatment is physical therapy, and it has to be gradual because the patient is actually in pain, and you have to explain the patient that hurt does not equal harm. So you'll have some degree of hurt, but then ultimately it's going to get better. And aerobic exercises are better than strength, but both the exercises should be offered slowly and gradually. The medications which usually are used are, as I've explained, that the deficiencies with serotonin and norepinephrine. So my first line of treatment is with amitriptyline, that is a tricyclic antidepressant, which induces sleep also, as well as acts an antidepressant. You have to educate the patient, because in the days of Google, patient will suddenly come to you and get, this is the antidepressant medication, why are you giving me this drug? Then you have to explain that these drugs in lower doses act as a pain management drug. So a good 10 to 25 milligram of amitriptyline, and then we'll add duloxetine slowly. You have to slowly increase the doses of these drugs, because these drugs have side effects. And if those side effects are predominant, the patient's compliance goes away. Patient will stop taking treatment. Milnacipran is not available here. I don't know, it's available in other areas also or not. But my preferred choice is amitriptyline with duloxetine, and then slowly increasing the dose, along with pregabalin, which is an anticonvulsant, but then nociceptive influences can be very well controlled by this drug. This also drug also causes drowsiness, so the dose of this drug also should be slowly increased. Muscle relaxant, which is a sedative cyclobenzaprine, 10 milligram at night, induces sleep and causes the muscles to relax. NSAIDs I don't usually use as if there is no inflammatory component along with that, means a patient with an osteoarthritis of knee or a patient of facet arthropathies or all. Otherwise, the NSAID do not have much effect. Even opioids, also, I do not use opioid for non-terminal pain. My preferred choice as an analgesic is tramadol with paracetamol. Nowadays, people have started using ketamine, oral or intramuscular, which is NMDA receptor antagonist, and it has a role in curing the condition. Psychotherapy is also an important part of the whole, because your thoughts will influence your feelings. Your feelings would ultimately impact your behavior. So if the patient has negative thoughts like I'm not going to get better or I am not doing well, then you have to reinforce them that this is definitely treatable, and with your positive thinking, you will be able to tide over this crisis. So the role of psychologist is important. I usually send them to a psychologist or a psychiatrist. Some of their patients have some taboo going to them. So you'll have to explain them and show some videos and something so that they will be able to understand. Another thing is biofeedback. That is a scientific term of what we used to do in thousands of years, means meditation and vipassana sort of a thing. But then here in biofeedback, they apply sensors also. Means those sensors would measure your breathing, your pulse rates, your temperature and all. Means if you meditate well, all those, the whole idea is to activate your parasympathetic system, which will calm you down, reduce your anxiety, and ultimately act as an antidepressant. Intervention is not much role in fibromyalgia per se, but as Khyati said, if there are trigger points, then they can be dealt with intervention. Or there is a pathology in the spine, like facet arthropathies or degenerative disc disease, they'll have to be handled with interventions. So finally, it is a condition of central sensitization. You'll have to slowly explain the patient, not in the first visit or third or fourth visit, that this condition cannot be cured, but you can manage it very well with drugs, physical therapy, and social support, either from a husband or the family. But it is very important to diagnose the disease early, because it in a lot of healthcare expenditure, because once the patient reaches to us, the patient has shown to nearly all the other specialties, all the investigations are done for no avail. So it is important that it is diagnosed early. And fibrosis is definitely manageable with multidisciplinary approach, which is non-pharmacological for a long time and with pharmacology for a short time to tide over the crisis. So any questions on this? And can always, Dr. Dhruv can always add to this if he has anything more to add.
There is one question on the message that any role of the yoga and meditation in the fibromyalgia.
Sorry?
In the chat box, that any role of the yoga.
Yeah, definitely. That is what is biofeedback. Means making your parasympathetic system active. So that will relieve your anxiety. Ultimately, what yoga does. It is a wonderful treatment for a mind-body coordination. I believe in mind-body medicine because as your mind thinks, your body will react. So if you have a calm mind, you will have a lot of less anxiety, and the pain subsequently is less.
Is any role of the steroid? Is there?
Steroid no role. Dr. Agarwal, sir, anything you can add to this? Dr. Dhruv, Dr. Khyati, anything you need to add? Any questions?
Hello. Yeah, thank you so much, sir.
Dr. Dhruv, anything to add in fibromyalgia thing?
Sir, most of the things you covered beautifully, and as you rightly said, that when we talk about medicines and when we talk about the minimal interventions, it is not more than 20-30%.
True.
So the first things is the first meeting that I have is I generally do not prescribe medicines. I just talk to the patient, try to answer all their questions because they come with a lot of misconceptions which are based on the things which have been told by the previous consultants. So first
True.
is I just write it down, try to debunk all the theories and the conditions that they have been what you say sensitized about. And as you
Yeah.
rightly said, sir, beautifully put up, sir, is that you not only need to make the patient understand the condition, you also need to work with the family.
Yes.
Because what one of my patients said is that, doctor, I'm already fighting a battle with my own body. I do not want to fight one more battle with my family.
Yeah, it's truly a biopsychosocial
Definitely,
thing.
sir. Because see, as I think it was discussed also, taking care of the pain is definitely difficult, but taking care of the surroundings is easier. So if the patient, attendants, and the family understands that the person is not faking it and the person is actually in pain, then the recovery becomes easy. The patient is in a better condition to get better.
Sure, true.
So that is a very valid point, and that is something that we have to reinforce. And as you said rightly, I strongly recommend. I also have a written material which is both in English and Hindi, and I will request everybody in the audience. I think they are from all our states. You should have some written material in vernacular languages because there is decent amount of literature available on the net in English, but when it comes down to vernacular languages, the situation is very dim. So and it is rampant. It is across what you say social class. It is across urban and rural divide. So I will request everybody to just chip in so that they are able and they have their own colloquial terms to describe it. Then the things and the treatment becomes easy. Otherwise, it is quite challenging.
Yeah,
But
it's one of the most difficult conditions to treat in pain medicine.
definitely, sir. And one more thing is what I always tell my patient is that rather than chasing a pain-free body, let's talk and discuss about functionality.
Yeah, true.
So what all things in their daily life, when I say daily life, it is not only restricted to their professional life, professional, personal, intersocial, what are the things that you want to achieve? And let's sit down and have a plan for those all activities. So rather than saying that pain will get better in this, because at the end of the day, whatever is a clinical condition, we really want to be functional. So what when I am dealing with these
Absolutely.
kind of patients, I am trying to talk and I am trying to devise a plan based on their lifestyle, based on their expectations, how to make it a more functional life. But yes,
So,
it is quite challenging and quite an humbling experience. But yeah, it can be managed. That is one thing, because people, it can be managed, and trust me, they are your most loyal patients.
so
If you develop that rapport with fibromyalgia, they will travel across states, across countries to have a consultation, spend some time, you do whatever, they will never leave you. Everything is well contested, but conditions like fibromyalgia is a barren land, and this is where we can chip in. And I think Dr. Agarwal, when he was starting off, he also mentioned about it, that it is these kind of patients are our responsibility. They are challenging, but this is why we had this specialty. So this is our responsibility, and we should not run away from them. Yeah. Thank you so much.
Excuse me, sir.
Yeah, sir.
I have one case. Can we discuss that case?
I think at the end, or whether Dr. Thakur
I
allows.
think we should be discussing at the end.
There are so many questions is there in the chat box. So first we finish the lectures and then we will make the
Yes, sir. Yes.
forum for the open discussion, sir.
Okay, sir. Okay, sir. Thank you.
Okay, fine.
Dr. Dhruv?
Yes, sir. Am I audible? Am I visible? And are my presentation seen, sir?
Yes,
Yeah.
sir. I give some short introduction. Already all the people know about Dr. Dhruv. Dhruv is attached with the Delhi Pain Management School in the Delhi, and he's a national and international speaker. So I not give the much time, not take the time regarding the introduction. Give the mic to the Dr. Dhruv.
Thank you so much, sir. Thank you so much for giving me this opportunity, Dr. Thakur and the entire ISSP Surat City branch. I have a small Gujarat story. I did my graduation from a place not very far from Surat, that is Baroda. I am a Baroda MBBS MS University. So I know the culture and the wonderful state that Gujarat is. So thank you so much for inviting. Regarding the topic, because it was botulinum toxin and MSK pain, I've just, because it's a relatively new molecule which are not being discussed, so I have just taken the liberty of expanding the topic to include what does botulinum toxin has in when it comes down to in pain medicine. So before I start, I would just request everybody to sit back, relax. There is nothing, what should I say, path breaking that I have done. You can have my presentation. What I really want you is to have a clear understanding and get the fear of this molecule and to start using it in your day-to-day practice. And I can reassure you, because all the other things take certain level of time to master, to use. But when it comes down to botulinum toxin, that is something that you can start doing immediately, maybe from tomorrow. Because at the end of the day, you need to know that it is nothing but just a simple intramuscular injection. So you just need to inject in the right muscle. With that, let us start with a small history. I'm a history buff. I love history. And botulinum toxin, as I always say, that if it would have been a character, then it would have made a good blockbuster movies. Because as you all know, botulinum toxin is the most potent toxin known to human mankind. Now, it was first discovered way back in the 18th century by this gentleman, by the German physician, Dr. Kenner. What was happening is during the war times, a lot of German soldiers were dying. And what they identified was that there was some sausages which was being contaminated by something which was causing it death. So that is why it came the first name, which was called as a sausage poison. It continued for some time. It was one of his students, Belgium Dr. Mengen, who worked on it and identified the toxin and as coming from Clostridium. botulinum and the toxin as botulinum toxin. And for a very long time, it was one of the most potent toxin known to human mankind. And everything which is such a potent molecule is bound to attract a lot of attention of a lot of evil people. And this was no exception. Allegedly, it was used by Adolf Hitler himself as a bioweapon in the Second World War. So from being a poison, it came down to being one of the most deadly weapons known to human mankind. And for a very long time, it was a toxin till Dr. Scott, who is considered to be the father of the botulinum toxin, as we know right now, who was the first to talk about the benefits of using it in clinical conditions. And the first conditions were strabismus, blepharospasm. He was basically an ophthalmologist, and that's how it started being used. The story doesn't end here. From it being used for medical conditions, people soon realized that it is basically a neurotoxin which is causing muscle paralysis, and it had its use of in cosmetic for cosmetic conditions. And the biggest challenge which even I face and you would be facing very soon is the moment you utter the word botulinum toxin, the first thing is said, sir, that is for heroines and that is for cosmetic. And then you have to reassure that no, it is used for pain conditions and also used for one of its side effects was something which the cosmetologists have taken up in a big way. So this is such an interesting molecule that we will be discussing today. So what is the mechanism of action? I think basics of neurotransmission was covered beautifully by Dr. Khyati in the first talk. So basically what is happening is that there is synaptic vesicles which will release acetylcholine. Synaptic vesicles. Now synaptic vesicles have to attach to the nerve terminus. Now that takes place with the help of SNAR proteins. And once the acetylcholine is released, there is muscle contraction. Now botulinum toxin acts on these SNAR proteins. So what it happens is, because it acts on the SNAR proteins, it breaks down the SNAR proteins. And once the breakdown of SNAR proteins happens, the release of acetylcholine is stopped. And once the acetylcholine is stopped, there is muscle paralysis. So the contraction relaxes and the muscle becomes flaccid. But because it's a toxin, and it is the blockage or the thing, there is new production of SNAR proteins. That is one. Therefore, whatever action of botulinum toxin happens, it is time bound. It is totally reversible after some time. That is one. Second thing, what we need to understand is that eventually it is a toxin. Therefore, there is going to be an antibody formation in our body against this toxin. Now, briefly, I will just like to talk briefly about the structure. So, and everything will have a clinical relevance. So, if you look at this photograph of botulinum toxin, you will realize that one, there is a carrier protein. Second, the blue one is the core neurotoxin, and then attached to it is also some inactive neurotoxin. The action is going to happen just because of the potent neurotoxin, which is represented as a blue color. Rest of it is just paraphernalia. Now, why it is important to understand this concept is because you will realize that the larger the molecule is of a toxin, there is going to be a larger immunogenic response. A larger immunogenic response will lead to a more antibody formation. Therefore, when we talk about first generation botulinum toxin, in those scenarios, what you will have is, firstly, there is more immunogenic response. Therefore, when you consider repeating it, the time interval will be more. The chances of allergic reaction or immune responses are more. Whereas when we have a smaller molecule, it is stable, less immunogenic, and less antibody formation. So when we talk about onalobotulinum or Botox, so there are basically A to G types of botulinum toxin, but clinically we are using only two types, A and B. Along with in that also, basically in India, what we are using is botulinum, which is the common term Botox, and the incobotulinum, which is Xeomin. So there you can see that the difference lies between the molecular weight and the accessory proteins. So less accessory proteins, less immunogenicity, less antibody formation. Therefore, they can be clinically given after an interval of say 6 weeks. Whereas when you are injecting botulinum or Botox, there the time interval has to be 3 months. This is the only one thing which you need to understand, is that when they in botulinum toxin, we need to keep repeating these injections because they have a cumulative effect. One will add to another, and the subsequent cycles will have a better response. But the time interval is defined by the salt that we are using. If we are using incobotulinum, we can repeat it at 6 weeks. Whereas if we are using in like a standard, the origin botulinum toxin, Botox, there we have to have a longer time interval. Okay. Obviously, immunogenicity we have discussed. You can make these switches based on it. Cost is comparable. That is one thing which we are concerned when we are using botulinum toxin. Okay. Now, with that background about the history and the preparations that we have, how do we prepare it? Now, because it's a it's a costly molecule, it will require a certain level of expertise or certain few points which you need to be aware when you are making these preparations. Once you get comfortable, even your technician can do it, but I will request for few things you need to do it. The first thing, so whenever young doctors start doing their first case, the first thing that they tell me is once they open the vial, I cannot see anything in the vial. So my friends, the vial will remain empty. Maximum to maximum, you might see a thin white line right at the base. Right? So that is one thing. Second, what is the diluent that we use? We have to use normal saline. Third is, how do we mix it? We gently mix it, because you need to understand that it is a toxin. It can be broken up. Therefore, when you are mixing, you have to be gentle. Once stored, once you have reconstituted it, you need to use it in 24 hours. Practically, what I generally do it, I use it immediately. So I reconstitute it and inject it immediately. So how do we then, since I told you that it is an empty vial, how do we identify whether the drug is potent and it is working or not, the potency? So this is how. So it is a vacuum dried. So you can just see in this video that so it is vacuum dried. So the moment you put in normal saline, it will be sucked in. And if it is not being sucked in like this, you should discard the vial and give it back to the company. The company will replace it. How do we mix it? So this is generally we mix it. Where do we do the procedure? We are doing the procedure in an operation theater setup. As discussed in the initial part, we are from anesthesiology background. Things can go funny. So please, I will request everybody that do not be influenced by Western videos. Do these interventions in an OT setting with basic monitoring done. They can be done in an OPD setting also, but try to do it under the OT setting, OT setup. Now, how do we dilute it? Now, this is something which comes, so you do your calculation, and I will just go through the calculation, but still, if you want, once after the talk, or you can direct DM me to find out. So what is there? So these vials are present in two concentration. One is 50 international units and another is 100 international units. So let us start with the most common indication, which is the headache or chronic migraine or chronic drug resistant migraine. So in that scenario, we have to inject 5 international units in 31 sites. So basically at one point, you have to inject 5 international units. So how do we do it? So what we generally do is we inject around 4 ml of normal saline in the vial containing 100 international units. So each ml will have 25 IU. So total of 4 1 ml syringes having 25 IU. So what we need to inject at those spots would be 2 divisions or 2 kappa of that 1 ml syringe. Right? So now this is for smaller conditions like migraine, blepharospasm, facial tics. But when you have to inject it, say for example, cervical dystonia, here you have to go up to 30, 40 ml. You can do the same thing, or you can reduce it. So you can even do 2 ml in 100 ml. Therefore, one division will have 5 international units. Sometimes when you have to inject in biceps and triceps and quadriceps, you can have a different configuration. So what I will do is reconstitute. Before reconstituting, identify the muscles, get your calculation intact, stick it on a paper and do it. Because this is the only part where you can go wrong. Rest, you cannot go wrong. So do your calculation, identifying the muscle. This is the second. First is reconstitution. Reconstitution has to be done based on the muscles and amount of IU that you want to inject. And then would be the second part would be the identification of the muscle. Now, people who have interacted with me or we have discussions around my intervention. So basically, what I always tell is that when we talk about interventions, we are talking about taking sniper shots, taking those precise injections at the right site, at the right muscles, will decide between a successful and a non-successful block. So here you need to have that precision. Precision is the key when it comes down to pain medicine, and injecting botulinum toxin is no exception. Here we have to be precise, but at the same time, there are going to be multiple shots. So as a sniper, you have to have targets, and as an assault rifle, you will have to have multiple shots. So how do we identify the muscles? Now, this precision will come. So there are various ways in which we do it. One is definitely the anatomical landmark techniques. So that is something for, say, for example, if we are doing for face, anything regarding to face, because it's a single layer muscle, simple to identify, you can simply do their anatomical actions, ask them to contract and relax, you get an idea. Then if there are multiple layer muscles, what we use is USG. What the neurologists inject and what they are using is they are using a lot of EMG guidance. I personally in clinical practice have not used EMG guidance, but yes, for demonstration I have used. But because we are comfortable with USG, so if there are multiple layers of the muscles which are there, we can consider using ultrasound. In fact, we should use ultrasound. How do we double check it? So once we have introduced the needle in the muscle, the gold standard is we ask the person to do a contraction. So when you do a contraction of that particular muscle, by doing their action, you will see the movement of the needle. That will again help us identifying it. So we reconstituted, we identified, so where we use it. Now there are a lot of FDA approved drugs, and then there are certain drugs which we call as the off-label indications, and the number of off-label indications are just increasing. So where do we use it? Chronic migraine. So I will just like to expand that any headache which is not responding to standard line of treatment, or the patient has medication overuse headache, the patient has started developing side effects to drugs, or patient wants a drug-free period, in those conditions, you can consider going for botulinum toxin. The chronicity of headache or will diffuse the characteristics. So, for example, I might talk about features of chronic migraine, but in a real scenario, chronic migraine will have some features of chronic tension type headache. So, what I say is any long duration headache impacting their quality of life, drug resistant, medication overuse, because that is also one common subtype that we come across. Along with that, spasticity, dystonias and hydrosis, blepharospasm, and strabismus. Rest off-label uses for which there is some literature is osteoarthritis, myofascial pain, and in cases of peripheral neuropathy and trigeminal also. So migraine, I have already discussed. Now, this is the one indication where I have seen good results, and we have done the decent number of patients when it comes down to using Botox. So in Botox also, so this is a preempt protocol which is freely available in the literature. So basically what happens is there are 31 sites where you are going to inject. Now these are the muscles: corrugator, procellis, frontalis, temporalis, occipitalis, paraspinal muscles, and traps. Now interesting part. So 31 sites, and you would say that I am requesting you according to the protocol to inject 5 international units. So that comes down to 155 international units of. Just give me a sec. I just need to put on the charger. एक second. Sorry. So 31 sites, and we have to inject 5 international units at each point. So that comes down to 155 international units. So what happens is there is 100, then there is 50. So what happens to the rest 45? So based on this protocol, they say that the remaining 45 international units, you should supplement at the site where there is more pain. So for example, if the patient is having more temporal pain, so you will give some extra units here. If the patient is having more pain on the occipital part, you will give some extra units there. That is point number 1. Second, common misconception: these have to be given bilaterally. Even if the patient is having unilateral symptoms, botulinum toxin always has to be given bilaterally. Why? Because it causes muscle paralysis. So for example, if there is a muscle paralysis, there might be a facial asymmetry. So this is again something that you need to counsel the patient, that there are going to be multiple injections, and these injections, irrespective of your symptoms, will be done bilaterally. So this is how we identify, we mark those points in these patients before we inject. So this is a simple thing how we identify it once we have done it. So this is, we just ask the patient to contract. Only thing is that we should not be injecting into the orbicularis oculi. It has to be the frontalis, because otherwise there are chances of ptosis. Temporalis. Now with temporalis, what they say is, you just imagine, you ask the patient, or you can ask the patient to contract, and once the patient contracts, you just put a coin and you just need to inject outside. The best thing is ask the patient to contract, feel for the muscle, and mark yourself, and then you keep on injecting. So what all the things that the patient needs to be told about is that there has to be no cosmetic, no creams, no shaving, no shampoo for the next 24 to 72 hours. What the patient generally complains of, there might be some pain, some brueness, some that should be it. And if those things happen, so you can just ask the patient to apply some ice. Very rarely would you be the patient will need an NSAID. Otherwise, sometimes if the patient is sensitive, you can consider patient to have some NSAIDs. How does the effect long? Firstly, with any chronic condition, do not promise the moon. Be very guarded when you are giving the prognosis. So when we are injecting botulinum toxin to the patient, what we're actually trying to do is, we are trying to reduce the frequency and the intensity of the pain. That is one. The drug consumption has to come down. That is one. Second thing is, how last. So it depends. I will be sharing my data that talk about 4 to 6 months. But one more important thing is that it is a cumulative effect. What I have seen is that in a patient, if I keep on injecting every 4 to 5 months, after 3-4, the frequency increases to more than a year or so. and sometimes the patient has or is able to manage with a single medications. When can we repeat it? It depends upon that botulinum toxin that you're using. So if you're using the first generation botulinum toxin, the gap has to be at least 3 months. Whereas if you are using the second generation botulinum toxin, it can be around 6 weeks. Advice after injections, I have already told you. Side effects, none. Blueness, some pain, some red spots, sometimes blue discoloration. Pregnancy, we do not have an idea. When do we stop the treatment? We stop the treatment when the patient's frequency reduces from chronic migraine, it becomes an episodic migraine. That is when we say that, okay, now you can manage with drugs. Prophylactic medicines, do not be in a rush to stop these medicines. Be very gradual when we reduced it. Okay, so what has been our experience? So this has been 2019. Now we have more patients. So what we realized was that initially we started with small doses because we were apprehensive. Gradually we realized that you have to be judicious with your use of your botulinum toxin that we are using, and we found out that preempt protocol was good enough. We have been able to achieve a VAS of less than 3 in around 60% patients with a mean effectiveness for 4.5 months. Now, apart from migraine, the other thing that we can do is spasticity. Now, that can be both cerebral palsy patients as well as uh, adult spastic patients, both upper limb and lower limb. Now, these are the muscle. These are bigger muscles. Therefore, they will require higher international units. Do not be so. Whenever a patient of spasticity comes, always try to identify the muscle which is causing it. And once you identify it, that is the time when you can identify and inject. One more important thing, when you are dealing with spastic or dystonia, that is a second indication, you need to understand the concept and you need to make the patient understand the concept. So in spastic conditions or in dystonia patient, what is happening is, because of the neurological condition, one group of muscle is stronger than the other group of muscles. So therefore there is a asymmetry. So what we are trying to do is we are trying to weaken the stronger group of muscles so that we get a window of opportunity of effective physical therapy to develop the smaller muscles, to develop the weaker muscles. Therefore, the effectiveness of these botulinum toxin in these kind of condition will depend upon the aggressive physical therapy undertaken by the patient. So this has to be emphasized to the patient, because sometimes the patient comes from various strata and they are not comfortable with this. So we always tell them, what we do is we ask the patient to learn physiotherapy, one of the parent to learn physical therapy. So they have daily sessions. Along with daily sessions, we ask the patient to do a physical therapy second session by one of the parents. That is one. Secondly, if we are dealing with spastic patients, specifically CP patients, we even do a plaster for 3 weeks to take care of the deformity. So we have conditions like equinus. We have conditions like when you have adductors which are stronger than the abductors. So we do botulinum toxin, we relax them, we put them on casts. Once the cast is taken out, physical therapy takes over. And again, what we are trying to do is a functional improvement. But this again has to be informed to the patient. Now again, torticollis, cervical dystonia, a challenging condition, good results. But again, proper planning. I tell all my postgraduates, people who ask me about it, is the easiest intervention, but planning takes a lot of time. So in case patients of cervical dystonia also, you will have my number at the end of the talk. Get a video, share it with me, and then we both can sit together and formulate a plan where about the drugs that we need to inject. Now, blepharospasm, again, here we are injecting in the front, in the procerus and the adjoining muscles. Now, this has been the story so far. Now, what is ahead of us? Now coming to those conditions. So what happens in botulinum toxin? There are studies which talk about that they even inhibit the release of glutamate and substance P, but that is in rats. So extrapolating it, people have started studying and using it in conditions of chronic myofascial pain. But you need to understand that this cannot be the first line treatment. So where you have tried everything, the patient is not giving us the patient is not getting relief, their functionality is being impaired. That is the subset where you can consider using it. Now there is a lot of things. See, what you say, spasticity is something which people are concerned about, and there have been few studies which talked about that they are able to take care of synaptic plasticity by causing modulation. That is one. Secondly, they have also found out that they cause structural changes in the muscles, cross-sectional and connective tissue fibers over time. When you keep on repeating it, so it calls upon substance P, there is action of on the synaptic modulation and muscle fiber. But is when we talk about in this botulinum toxin per se, over chronic use, what it predisposes the patient is that there can be reduction in the cross section of the muscles. So muscles also is becoming weak if we are continuing to have it. Therefore, these are the newer indication where we are, where like myofascial pain. Piriformis syndrome definitely is something which I have given around 5-10 patients of piriformis syndrome. But again, piriformis syndrome, as we all know, firstly, we need to be sure about the diagnosis. And once we are sure about it, then we can inject botulinum toxin. Plantar fasciitis, epicondylitis, ONE, and trigeminal neuralgia. ONE, I'm not very happy. I have not given much to the patients. Trigeminal, maybe can be tried. Not many cases unless the patient purposefully asks for this kind of intervention, I wouldn't be giving it. Okay, I would just like to end. It is a beautiful, wonderful drug. Trust me, it is a safe drug. Even if you inject another muscle, it will be reversed in 3 months. Identification of the muscle is the key for the success. Proper prognostication is the most important in case of spasticity. And trust me, my friends, once the patient knows that you are able to inject Botox, then even you can do cosmetics because dermatologists and others charge more. It is a beautiful molecule. Only thing is that they have a little bit of high So once you get comfortable, you can do all those fillers and everything, which it is infamous. These are my contact details. Feel free to get in touch with me. More than happy to answer your questions. Sorry, took a bit of time. Thank you so much.
Thank you. Hemifacial spasm?
Yes, sir. You can inject. Again, you have to identify the muscle which are the troublemakers, and then you can inject.
Okay.
But again, you will have to. Yes, sir.
For your wonderful presentation, wonderful videos, and wonderful practical tips. Now I open the participants to ask the question to the faculties, and I have also changed the settings. The participant can unmute themselves, but be sure that please raise your hand. So and do the unmute after that, so we can prevent the cross talking and cross questioning. There are also some questions in the chat also.
I have one or two questions in the chat box. Is ketamine therapy for fibromyalgia? Ketamine is a very good molecule, helping in overcoming depression. Also, it's a good NMDA receptor antagonist. Can do it, give orally also.
Yeah, so we are using ketamine, sir, for infusions for patients of fibromyalgia. So what we do is we give it for 5 days, for 4 to 5 hours. We start with 0.8 milligram per kg body weight divided over 4 hours, and based on the patient response, we keep on increasing it. We have gone up to 2 to 3 milligrams per kg body weight on the fourth or the fifth day. We pre-medicate the patient to with midazolam and MSET. Sometimes we add a little bit of propofol also. Only problem is that the patient might hallucinate. So midazolam is something that you will have to give. But yeah.
All of the Xylocan drip,
Lignocaine infusion for fibromyalgia, I don't know. There is no reference, but can be used in central neuropathic pains, some of the stroke or.
Yeah.
such pain, but no evidence in fibromyalgia.
Yeah, I agree, sir. So what happens is, because initially few years back we were giving Zylocard infusions, but with ketamine the things have changed. We have now shifted to giving ketamine infusions. Something we have done in very few patients is when the patient was not able to tolerate high doses of ketamine. We used to give a combination of ketamine and Zylocard, but that needs a lot of standardization before I can speak. But yeah, these are cost-effective things. So people, when they talk about chronic pelvic pain, chronic abdominal pain, CRPS, fibromyalgia, or for example, any condition which is suggestive of central sensitization in a low resource country, a low resource place, please do not hesitate to use ketamine infusions.
Fantastic results in even depression also.
Yes, sir.
With suicidal tendencies.
Yes, sir. Absolutely, sir. Beautifully said. And you will have these chronic patients having underlying depression. So definitely do not hesitate to use. And coming from anesthesia background, we are absolutely comfortable managing ketamine. So even if there is some sort of a sedation, you can stop the. Well, you can observe the patient and do a lot of things with them. I have even have centers in India where, or we have suggested where you have an inpatient facility. You give 24 hours for 4 days with one very high dose of 0.25 milligram to 0.5 milligram per kg per hour. So you can go dhire or 10, 15, 20 milligrams per kg. So that you can do continuously IV for 4 days. That also can be done. So it's a beautiful, wonderful drug.
There are 2 to 3 questions in the chat box. One is regarding the cost of the botulinum toxin, and another is regarding the EMG report.
I couldn't get you, sir.
So there is a 2 to 3 questions in the chat box. One is
Sure.
there is a role of the interpretation of the EMG reports.
EMG, no. EMG reports, yes, EMG reports. See, the EMG is used for identification of the muscle. That is one. EMG reports interpretation. What I have read is that it's important in patients of piriformis syndrome. But apart from that, I do rely on neurologists, so I'm not very comfortable using these EMG reports. But you can get an idea, so that can help you when you are targeting the muscle. So there you can ask for an EMG to find out which muscle, and then you can target that particular muscle.
Another is the cost of the botulinum toxin, sir. Another question.
You can if you are good at bargaining, you can get a good deal, but you can get around 30, less than 30 also it's possible, in which you also make some money. Rest I can DM you. But what I'll request, but one thing regarding the cost is, I will request, there are a lot of Chinese and Korean molecules which I am not comfortable. What I personally believe is, use it, tell the patient that this is going to be the cost, give the patient the benefit. Otherwise, you will not be sure, the patient will never be sure whether actually botulinum worked for you. So you as a clinician will lose interest, the patient will also lose that trust in botulinum, this topic. So what I'll request my doctors is, reduce your margin, because anyway it's just an intramuscular injection. You can get good deals from the companies. But please use an original molecule. Otherwise, you are never sure कि वो उस vial के अंदर क्या है, because it's virtually empty.
I have question for Dhruv sir.
Yes, ma'am.
First generation and second generation Botox, as in this Xeomin and Elargan. Clinically, do you see any difference in the outcome,
No,
except
ma'am.
for it can be
So
repeated?
what I'll tell you very honestly. Xeomin, I was one of the, I have done a workshop in last Issp. So it is more or less same. Only thing with Xeomin is that it can be frequently repeated. So that is one thing which I always tell my patients. That is one. Secondly, stability is not an issue. So you need not maintain a cold chain. Apart from that, cost is equal. Efficacy, both companies will claim, but they are equally efficacious. So whatever gives you a better deal, you go ahead and do it. Anything else?
questions in the chat box read to the Dr. Khyati. Have any experience or the share the study of the USD guided needling in the OAG?
As a sole modality, it won't be of much help. The basic pathology is osteoarthritis. So if there is associated muscular issues, yes, it will help. But if you are only relying on needling for OA, no, it will be very temporary.
All treatment should have beneficial effect on the lesion, ultimately.
Yeah.
And one more thing is, I always tell the success and the failure of all our intervention is based on the patient. So whether it is migraine, the patient has to work and identify on their triggers. That is one. आप botulinum toxin लगा के व्रत नहीं रख सकते. This is something which I have to tell everybody. Whether it is Ekadasi, whether it is Navratri, you cannot fast if you are patient of migraine and you are going for botulinum toxin. The same goes with ONE. So no matter what we do, you have to stop doing cross-leg sitting, squatting, even for pujas, even for everything. So that is something that you have to reinforce the patient. Then only these things work, whether it is this, even for fibromyalgia. If the patient is not able to pinpoint their psychological triggers, the physical triggers, bring about hardcore changes in their day-to-day activities, they will not have a functional life.
Acceptance of a disease is very important.
Yes, sir.
Counseling is also important. Counseling.
Yes, sir.
Counseling of the patient is
100%.
communication.
100%. I tell you, because this is an anesthesia platform, I can tell everybody can do all interventions. Trust me on this. The biggest problem lies with proper prognostication and communication with the patient. What they are expected to do and what there should be their expectations after the procedure. Fine, sir.
Any other questions to any audience or participants?
Fine, sir.
Dhruv sir, a question
sir.
to you.
पूछ ले भाई.
Sir, Dr. Sovir Thakade.
हाँ,
Sir,
बता.
I have tried few patients with local anesthesia for cervical dystonia and with or without steroid. They had good result for 5 months near about. And when we say the rate of Botox treatment and it will give a result of 1 year, maybe 1.5 year, or maybe 6 months, they back off. It is always a problematic thing.
Yeah, I can understand.
And if we are
just to interrupt you here. Yeah, just to interrupt you
Yes.
here, one thing. I think that was decided. See, with this, you are giving give local anesthetic. Don't give steroids. Do not inject so much of steroid in the muscle. That would be my thing. And that was something even Dr. Khyati talked about. Give local. Don't give steroids so much. Repeated steroids do not give. Once, yes, but do not give repeated, because you need to, because what we are giving is a depot steroid. Right. So when you are giving depot steroid, something will stay there, might cause muscle weakness and everything. So do not atrophy. There is, because how should I put this? Because now I have been into practice for 15 years. So what happens is, you inject now, so sometimes you find out that there is some sort of a granuloma type kind of a thing. So if you are giving 100%, it will there is a possibility. I won't say 100%, but there is definitely a possibility that simple local anesthetic injection, saline injection, even dry needling might work, right? But I would suggest avoid giving so much of steroid unless you have clear-cut indication that there is an inflammation involved. Yes, sir. Sorry, I interrupted.
No, thank you so much, sir. Second question, sir. In spastic condition such as cerebral palsy, rhizotomy versus Botox. Have you any study on that?
Study का तो मुझे नहीं पता. I'm actually a lazy guy. I do not go. But so the thing is, botulinum toxin is something which is standard, which has got a lot of studies. But if the patient has what you say, limitations with finances, then you can go for a phenol block. I have not done many, but I happen to work with Professor Dureja, and he has ample number of patients where he has given posterior tibial nerve blocks and everything for spastic patients with a nerve stimulator and given phenol, and the patient had good relief. Only thing is the chances of neuritis are there, but yeah, that for that particular subset of patients, that is worth taking a chance because they will definitely have a functional life. Fine. Thank you.
Excuse me, sir.
Anji.
I have one patient. He is of around 55 to 60 years guy. He has been operated 30 years back for some abdominal surgery.
Ji.
Abdominal surgery. And in these last 5-6 years, he has got abdominal pain. His known case of hypertension, diabetes for pretty long time. He visited multiple consultants. He's on anti-diabetic drugs, antihypertensive. Along with that, duloxetine, pregabalin, all sorts of SSRIs, SNRIs he has received. He has suicidal thoughts also. And the last 1.5 years back, I saw him. So he was having very bad scar on the abdomen. At the same time, he has divarication of recti in the upper epigastric region, around 2-3 fingers wide apart. Okay. So after doing all USGs and CT scans, no of any finding was there. So that's why I asked him to do a diagnostic laparoscopy, as I was expecting adhesions. So we did 1.5 years back diagnostic laparoscopy. In that, as usual, the adhesions were there. Adhesiolysis was done that time. Along with that, we have started some pain relief medications also. With that, he has got a pain relief of 1.5 years. But again, since 15-30 days, 1 month back, he has again started pain abdomen with constipation and what you can say, sugars were on higher side. So I controlled his sugar. I started him on this Ultraset and other drugs. And after that, I gave xylocaine drip and this ketamine drip. With that, for 1 month, he was all right. Again, he has started getting pain. So what do you think? I'm asking 3 of the speakers whether dry needling has any role. And second thing, Samir sir, what do you suggest? And sir, Botox has any role in? He's specifically telling about abdominal pain. And that divarication of recti, is there any component of pain there because of this divarication?
Okay. Anybody, or should I start? Okay. Simple, straightforward answer. What I would suggest is, if ketamine xylocaine has worked, keep repeating it monthly. Simple, straightforward. That would be my single line thing. Because what happens is, in these kind of patients, you were lucky that you got adhesion, everything done, and still the patient did have pain relief. But what generally happens in these kind of complicated patients, the more interventions, the more invasive things that you do, the patient backfires a lot. So if you are able to achieve some sort of a pain relief with ketamine xylogard, go for it. That is one. Second thing, what I would suggest is, does the patient have scar neuralgia? Or the patient has diffused pain all over the body, all over the abdomen?
He has pain all around that scar.
So, no,
all over abdomen.
Okay, so whenever you have the patient of post surgery, anything, so always try to firstly palpate the scar. So sometimes what happens is, the patient will have scar neuralgia with neuromas which are present there. So you can give local anesthetic blocks repeatedly over that area. The patient generally desensitization happens and the patient settles down. That is one. If the patient is having diffuse abdominal pain, classically the patient will have some sort of a visceral pain, secondary visceral pain. In that thing, it is like a Pandora's box. So what is going to work, what is not going to work is dicey. But if you are able to give him 3 days of ketamine xylogard infusion, and the patient has a relatively pain-free day for a month, please keep doing it. Do not try to be more aggressive with your interventions. or doing any invasive investigations. That would be my suggestion.
Okay, sir. Is there any role of dry needling, ma'am?
Yes. So when there has been repeated surgeries, the abdominal wall muscles, external oblique, internal
No,
oblique
no
transverse.
repeated. Only once. Only once. 30 years back, only one surgery.
And he did not have pain for these 30 years, or he was like
He
on.
was pain free till 20, and after that another 10 years he has pain. Since 10 years he is having pain abdomen.
So maybe you could do check needling sort of, where you put in a thin needle, see if there are trigger points. If you can elicit LTR, then doing more needling sessions will help. If you don't elicit anything, then there is no point in doing it, and then you can go ahead with repeated lignocaine infusions.
Okay. Okay, ma'am. Thank you.
So, Dr. Jayesh, may I come in?
Yeah, you can.
Yeah. Thank you, Dr. Desai.
Sure, sir.
Hi, Dhruv. It was
Hi,
such a
sir.
wonderful thing, and I am so lucky that I could get time today. So attend the all three wonderful talks by Dr. Patel, Dr. Desai, and dear friend Dhruv. For the amazing things which I have already told, that this is one thing which most of the physicians taking care of uh, pain, they miss, unfortunately, barring the pain physicians, which we are. So we are happy, and as Dhruv rightly said, that this is our duty. We are duty bound to take care of these patients. Uh, Dhruv, I have one question with your permission to ask.
Arre sir, bole bole.
So,
No
bhai,
problem,
I just wanted to
secretary.
ask about what has been your experience with the tachyphylaxis thing with Botox.
Ge-
Like, yeah,
Generally, it doesn't happen, sir. I
okay,
have not seen tachyphylaxis happening.
okay,
I have discarded a few vials when I was not sure about the vacuum part. So I've discarded a few things. But because I have only experience with botulinum toxin as Botox and Xeomin, so I
okay,
haven't had tachyphylaxis.
okay.
Uh, the side effects that I have seen is that sometimes you inject in the wrong muscle and there might be some facial asymmetry.
Yeah, that is.
That is most common. So people who are starting off, that is one thing which I will request is just do a proper planning. Pre-procedure planning would be the key, sir.
Yeah, that is a very important. So there is no reduced efficacy because, when I read the literature quite some time back regarding Botox, so it was clearly mentioned that there with the repeated use, but they were talking mostly about the spasticity patients
Yes.
where they are using a lot of amount of drug.
Exactly, sir.
So they have
Absolutely right.
mentioned it. Yeah, they have
Yeah,
mentioned
definitely,
that,
sir. Yeah,
but not with
definitely.
the migraine patients. They
Yeah.
remain good. They remain responsive.
Because see, sir, because what happens generally, what we have seen in migraine patients or chronic headache patients is after third, they are in remission for a very long time.
Long time. Okay.
Spastic are generally specifically CP patients, or say, for example, spastic patient, adult patient, they have stroke and
Yeah.
everything. So, firstly,
Yeah.
as you rightly said, it is also directly proportional to the amount that you are giving. So,
Amount,
200,
yes.
300, 400 has to sometimes have to be given in adult population. Then
Yes.
becomes, usme to there is going to be an antibody formation and the
Yeah.
effectiveness will keep on reducing.
Acha, next question is related to that only. Just because you have already said that you have used Botox and Xeomin, I don't know about the current literature, that's why I am asking you. If unfortunately we find a patient who is having tachyphylaxis, reduced effect to one preparation, is it any role as per the literature for the switching the
We can,
monobotulinum to,
yes, sir, we can switch. We
we
can
can
switch.
switch? Yeah, okay, okay.
They are interchangeable also. So, for example, if you have used botulinum toxin, your Botox in the first sitting, you can use Xeomin in the second sitting.
Second. Thank you, thank you.
Thank you,
This
sir.
was in my mind. So,
Thank you,
Veer,
sir.
you asked one question. I would like also to pitch in, though Dhruv has already answered that, about the what was the question for the osteoarthritis thing?
Sir, dry needling in osteoarthritis.
Yes, and another question?
Sir, rhizotomy versus Botox treatment in
Yes. That
cerebral palsy.
rhizotomy thing. This I would like to share my own experience of few patients, not many. I have done a few patients with partial dorsal root ganglion rhizotomy in the lumbar and upper thoracic region. with few of the patients of the cerebral palsy who responded also partially. It was like Dhruv has already said that in chronic pain, unfortunately, we do not have the panacea. For most of our patients, they get better with some of the things, some of the drugs. So yes, it can be done. In few patients.
Deafferentation could be an issue.
Pardon, sir?
Deafferentation with rhizotomies.
Sir, that actually depends on the. It didn't happen with our patients,
That's good.
but yeah, it can happen, especially if you are using high temperature and longer duration.
Okay.
So neurosurgeons, some neurosurgeons who work in the field
RF
of cerebral.
ablation you did?
Yeah, I did RF ablation, sir. Yeah, partial rhizotomy at the 65 degrees centigrade for 60 seconds. And after putting our RF cannula on the dorsal root ganglion. So we did it and it worked. I won't say that magically, but it certainly relieved the patient from some of his agony. And for the last thing, I'm also pitching. I'm just taking like I'm putting my foot for the Dr. Mahmood. He asked the question about that abdominal pain thing. So I would just like to share that you have already done everything which could be done, but perhaps you can also check out for the ACNES, anterior cutaneous nerve entrapment syndrome. And most important thing, which Dr. Dhruv has already mentioned, that to look for the scar neuroma, which is not there in as per.
Okay, sir. Means I have to just palpate on the scar.
Yes, yes. This is very, very important. This is very, very common actually.
And
they usually respond very well for the scar neuroma thing. Botox works very well. You put a
okay, sir.
few internulation units and you see that they works. Usually it works very well. And the last thing I would like to pitch upon the use of steroid in the during the dry needling thing. Like Dr. Khyati Patel has beautifully explained that perhaps yeah. I am personally, I don't use either local or steroid because both of, if you go to the literature, both local anesthetic as well as steroid more, local anesthetic less, but they are myotoxic. So I personally don't like to use. I use only dry needling, and in most of the patients, if the diagnosis is correct, if I have located the trigger point and I have done multiple passes, Dr. Khyati has already told, and see the NTR thing, it works like charm. One of the best thing which you can do without any cost actually to the patient. You can charge whatever you want, but the patient gets relieved and they can proceed. So once again, with this, my inputs are over. My questions are also over. I again I'd
Sir,
like
one
to
of the
congratulate.
questions you
Yeah.
wanted to tell something about dry needling and osteoarthritis.
No,
You
actually, I
were
didn't want
giving
to
some
say.
input.
Dr. Khyati has beautifully answered. The problem is with the
Sir,
joint. So you have to treat the joint.
yeah.
Along with that, if you are finding any trigger points, because I can add something. This is what that the PRP thing or all the intra-articular MIPSI started with the invent of prolotherapy actually. And if you go back just 10 years back, you see the videos of the prolotherapist in the US where it largely started apart from the Europe. They used to give lot of peri-articular injections of prolo agent, whatever they are using, dextrose or anything. So yes, they used to do it. And I personally, when I used to do prolotherapy some now 10, 12 years back, then I used to do that. But the only problem with that is the multiple injections make the patient harassed.
हाँ exactly.
Yes, sir.
मतलब एक इंजेक्शन के लिए you keep 6, 7, 8 injections. So patient and that too is with an irritant fluid. So the
Yeah.
patient का osteoarthritis की जगह दूसरा pain हो जाता तो
Patient become harassed and I used to become harassed, so I stopped it doing it.
नहीं
So Dr. Khyati has already told you that in our opinion, no, it is not going to. This is which we all can say with some confidence. It is not going to work in the singularity.
Yes.
It is not going to give that help the patient of osteoarthritis.
Yes.
So thank you once again, Surat City Branch, Dr. Desai sir, dear
Thank you.
Jayesh, and Dr. Khyati, Dr. Dhruv, Dr. Desai sir,
Thank you,
and
sir.
all the participants. Wonderful session. And I
Thank you,
take your leave with these words.
Thank you, sir.
So Dhruv, if
Thank
you can share your presentation to
Sure, sir.
Jayesh or
Sure. कोई
some
problem ही
of
नहीं sir.
the injection points and
I'll
all.
share it with Dr. Thakur.
Okay, sure. Thank you.
Thank you.
Okay, last thing from my side. This is I am duty bound to do that. Please, all of you are requested and invited for the Hyderabad ISSP Con, which is the 40th conference. And you, all of you, if you are not yet the member of ISSP, please become one. And third thing, that please share the ISSP handles and follow them on all the social media handles. Because as I told you in the my opening remarks, that we pain physicians are to become the primary custodian of all chronic pain syndromes. So we are duty bound to do that. India is going to face, and actually world is going to face the tsunami of chronic pain patients in coming years. We all will see that. So we have to be best prepared for that. This was the last thing.
Sure,
Thank you
sure.
once again.
Thank you.
Thank you.
Thank you all.
Thank you. Good night.
Thank you so much, our National President Krishna Madam, Anurag Sir, Surat President Dr. Samir Sir, all these faculties, Kathy and the group, Dr. Dhruv, Dr. Samir Sir, and all these participants who contributed in these sessions and attending these sessions. Thank you so much.